So welcome everybody to our webinar on acute care for caregivers. Family Caregivers of BC is a nonprofit charity dedicated 100% to the well-being of family caregivers. We've been around for 28 years, and we were the first of our kind in Canada. There are now 2 other provincial caregiver organizations and a new one that's going to be formed in Ontario. So that's good news for the folks that join us from back east. We have been serving all of BC for the past, 7-8 years now, and 4 years with funding from our Ministry of Health Patients as Partners provincial program. All of our staff have caregiving experience, and 60% of our board members. So we have walked in your shoes, and hoping that makes us really good advocates for your role as family caregivers. A quick slide here just to show you the different things that we do. The most important piece of information is our website, which is throughout this slide and also at the bottom. We offer one-on-one caregiver support through a support line, one-to-one consultation sessions. We help support groups get established throughout the province and have an extensive online resource center. As well, we offer webinars like the one today and a quarterly newsletter. And we also recruit caregivers to be a voice for caregivers with health system improvements. So if that's ever of interest to you, we'd be very interested in hearing from you. For those of you who may not have been in a webinar before, confidentiality is essential. Each person has the right to participate or not, and anything that you have to say is most welcome. And I will try to make sure this is going to go fast because it's just an hour, but I'll try to make sure that anyone who has a question or an observation gets some airtime. And just be thinking about the fact that not everything everyone says will apply to your situation, but it is an opportunity to kind of self-reflect and think what might. So today's presenter is Wendy Johnstone, and Wendy does a lot of work with us here at Family Caregivers of BC. She's a gerontologist with over 20 years of experience working with family caregivers and seniors. In addition to her contract work with Family Caregivers of BC, Wendy runs her own company in the Comox Valley called Keystone Elder Care Solutions. So thrilled to have Wendy with us today.
Thanks, Janet.
I will just cover the learning objectives, and then Wendy will take it from there. So the inspiration for this webinar actually came from one of the members of our staff who had just recently been going through an episode with her mom in acute care, and we just took notes. And so what you're going to see is this webinar flows like a bit of a bunch of scenarios with some think-throughs, but that's how we often have to approach these situations. It's in the moment, and you have to be able to think on your feet. So our objectives are to help you think about an unplanned visit to acute care, understand what might make that visit more productive, give you some tips on how to interface with acute care staff to get the best results, and provide you with tools that you can use to prepare for unplanned visits. So Wendy, over to you.
And go. We've got 57 minutes to cover an incredible amount of information. Welcome, and thanks for having me here today. Acute care is, when visits to the ER or the emergency department are probably one of the most difficult parts of caring, just because it's typically unplanned, and there's lots of different possible scenarios that can happen. So one of the scenarios that we've come across or we've heard about or experienced personally is that it's quite late in the evening, and it's pretty clear that things are not going well for the person you're caring for. It might be related to health. It might be related to a mental health issue. There's typically no clinics that are open, but you're not really sure what to do. Do you typically call the health link? What are they going to suggest? What services do they provide? And then if you're referred, if they tell you to go to the emergency, what then? I think I can, there we go. Okay. So some of the think-throughs that we've noted are often helpful is the person that you're caring for have in a very acute fever that's, spiked very quickly, or do they have some really, really signs of confusion that have come on very quickly? Maybe there's some paranoia, maybe there's some hallucinations, or they've had a real sudden behavior change. This is really important because it typically describes that there's something quite serious going on. So any type of, delirium, as they call it, or any type of, major fever usually indicates that there's a major infection going on or the body is in major distress. And that really should be taken seriously. So typically, in that scenario, the question then becomes, what community do you live in? So, for example, if you live in a small community where your hospital is located far away, do you wait and call 911 and wait for the ambulance to come, or are you in a position to be able to take that person to the hospital yourself? The other question, I guess, is, for example, if we're talking about a fever, some confusion, but it's been a gradual process versus acute, the question becomes, well, do you wait for some medical, or do you wait some time or through the night to see a medical professional in the morning? In my experience, when I call Health 811, if I were to describe a situation where there were signs of confusion or a sudden behavior change or an acute fever, it seems in most instances I get referred to the emergency department. Okay, so that one. So I'm not sure if anyone has had, other experiences or if they've had similar experiences with Health 811. You're welcome to share those in the box if there's been something that has applied to you differently. So in that particular case, let's say we end up, going to the emergency department. It doesn't matter how you get there. What's interesting is, for example, if your aging parent or the individual you're caring for lives in community living or assisted living, then typically having the paramedics come and do an assessment can be very worthwhile, and have them transport up to the hospital, and because they'll often call ahead of time and say that someone's coming, and then following through in a vehicle, of course, to be an advocate is really important. So in this scenario, determine that you need to go to the emergency department. What should you be taking with you? How long should you be prepared to wait? And should you be prepared for a possible admission? Before we go on to that, Janet, can I just take a few seconds and just maybe explain to people the value of having the emergency department checklist?
Oh, absolutely.
Yeah, okay. So below the presentation, there's a file that's called Surviving Trip to ER _FCBC. And what that is it's kind of a handy do-it-yourself information that you should be bringing to the emergency department that you should have already completed ahead of time. So typically it includes some emergency contact information, medical history, current medications. Typically if there's a representation agreement that's been completed, then having a copy of that, and it's in a, can be kept in a file. And for anyone who has an aging parent or an individual with a chronic illness or other disease that's living alone, it's often a really good file to have handy and to have it taped or have it adhered to either the back of the front door or near the kitchen, because that's typically where the paramedics will look when they come in. We have some very basic vials of life that you can get from different pharmacy shops, and it's kind of the same thing, but it's in a very small vial, and you keep it in your fridge or your freezer, and paramedics often will ask, or they'll often look there if the person's alone. So that would just be something that I would certainly encourage family caregivers to do, or if you're actually a senior living alone or someone who's living alone in the community and you have a history of health issues, it's a great bit of information to have ahead of time. So back to the scenario here, we'll just go in terms of having some think-throughs. and so we've covered some of these already. So do you have a list of medications your care recipient is currently on? And that would be the advantage, of course, of having this ER kit ready to go, and in terms of their issues and medical history. And copies of power of attorney and representation agreements, again, would be super helpful. So anticipating a wait time and taking things that will make it possible for your care recipient to feel more comfortable. Prior to any tests and diagnosis, usually they have a no drink or no eat policy. So if you are traveling to the hospital, or if your individual, or if the care recipient is being transported, they will have a no drink and no eat policy until tests are done. So just that's kind of a good reminder. I've found the hospitals, and especially the emergency department, to be quite cold. They typically have those great warm blankets that are available for individuals, but typically it's quite cold and quite chilly. So just having that preparation piece. Typically people go and they don't have shoes on, or they don't have jackets. So if you have time to collect some of those materials ahead of time, so it's not always the case, right? If it's an emergency, you go and then you can go back, and pick up things. But typically it's nice to have a few comfort items around those components. There's nothing worse than not having a pair of shoes and trying to leave the hospital, especially when it's winter outside. So, but it's amazing how we end up there with none of these items on hand. And if you have any other suggestions or any other tips that have worked for you or that you've noted, I certainly would encourage you to make note of them in the chat box too. So once you get to emergency, you've arrived there, and I'm going to try not to veer too much here, but I want to talk about two kind of possible scenarios, because if you have someone who is in emergency and you've been notified and you don't live in the same city, then it's often very helpful on kind of how you present yourself over the phone. But obviously if it's in person, then you actually are physically there. So the scenario is that you've arrived at the emergency department. How do you interact with the intake or triage nurse? What information is most critical? How do you request to be included in discussions with other healthcare professionals? Who are the other healthcare professionals and what are their roles? And which are the ones that you most need to connect with? And every hospital is slightly different, and every emergency is slightly different. And I think that's really important to to acknowledge that the information is as generic as possible, but there are some subtle differences, and some emergency departments have different programs for different populations. And so that's going to be a really important question to ask if there's any kind of specific staff who are dealing, say if you are dealing with someone who does have, let's say, a frail elder, then being able to ask if they have a specific program that's dealing with, geriatrics in the ER department. Sometimes they do have that, or they have a specific staff person that's going to assist with the discharge piece or with the admission piece. And or other times, if it has to do with mental health or substance use, sometimes there are some specific programs. So that's important, an important question to ask. So as we're thinking through the communication, of course, there's the 5 Ps, which is polite, positive, patient, purposeful, and persistent. It's really important to let them know that you're a family caregiver and that you have that care recipient's consent to be included in his or her own care and planning. Of course, this gets a little bit tricky when the person has some major acute delirium or dementia. That's why having a representation agreement on hand is also really helpful. And
we've got a couple of questions here, Wendy, before you get too much further. Shamai is asking about 811 versus 911 and saying, would it be a legal issue if you're responsible for someone and don't call 911 and then that person actually dies?
That's a really good question. I don't know.
Yeah, I'm not sure either.
I've never. I'm just trying to think of a the scenario where.
I mean, you're not a medical doctor, so or a medical doctor, professional. So how can you be expected to know it's that emergent? But I don't think they could hold you responsible. I don't know. Unless someone was choking.
I'm not sure. Yeah, I mean, we can certainly follow up on that.
Right.
But my sense is something like I'm just thinking if I was in a I don't know, in a car accident or something. I'm just trying to think of those, kind of a similar scenario. I think that's a legal question. I have no idea.
Yeah.
So
good
we're
question,
happy
Shemai.
to investigate and get back to you, but I've never come across that personally.
And then Arlene's question is about, is there a difference between saying I'm a family caregiver versus saying I'm my father's daughter or next of kin or?
Mm-hmm. Well, I think next of kin certainly suggests that you're a relative, a family relative. In terms of what language do you think is more acceptable? I think, when we're in hospital settings and we demonstrate that we're a family member, whether it's family caregiver or I'm my father's daughter or I'm my son's mother, I think all of those are going to have the same weight in terms of the fact that we're a family relative. I think where it becomes most important is that there's consent, that they understand that you're able to be part of that process and that you have consent from the family member. So when I do this type of work professionally, it's obviously a little bit different. I usually have to take the health professional in with me to the room and ask the client that I'm working with to give them verbal consent that I can be part of the information gathering, because different types of professionals will give you different types of information. So depending on, so for example, physicians are the only ones that are going to be able to give you results of tests, whereas nursing staff or other clinicians can only perhaps kind of give you a very kind of general view of health status or functioning or some observations and what's currently being done. So that information is important, for anyone who's assisting the individual in hospital. So I don't know if that helps or not. I mean, I think indicating that you're a family member and that you have consent, sometimes you might have to use a different label. If family caregiver is not working for you, then to go to I'm my father's daughter and he's given me consent to be here and be present and to take notes and to help with decision making.
Wendy, and just a quick question. Mm-hmm. Have you come across, do people actually have written consents ready? So, for example, if I'm caregiving for my mom, and, if there's something that happens to her and she may not be able to provide consent in that moment, would a written consent, is that something people do as part of the package?
That's usually in your representation agreement.
Okay.
Yeah, that's usually covered in the representation, which is why it's so important to have a representation agreement and to have a copy of it, so that, because even if you aren't on that document, then it's going to tell who is on that document, and that's the individual who they're going to want to call. Most people where possible, have a local individual be the representation, be their healthcare directive in that document so that they can respond rather than having someone who lives halfway across the country. Mm-hmm. Right, yeah, so some hospitals refuse to show the husband to the wife, the representations are really needed. Yeah, I mean, there's lots of different scenarios that can, that can occur. And again, it really does depend on the hospital. But having those representation agreements is really, really important. But then in other cases, sometimes hospitals and emergency departments are just so happy that someone's there with that individual, that they're often quite happy to, kind of share information. It's typically maybe around, decision making around future treatment. That's when I have found by experience that it's been the trickiest. So, for example, a family, I had a long-distance family that was working with, their aging mother was hospitalized, and I was part of that process. And they were happy to share information with me, but kind of at the end of the day, they were indicating that, they felt that she could make that decision if she wanted treatment or not treatment. And because the family didn't have that representation agreement, but even the physician felt that she could direct her own care. So in that case, it became really tricky because she was demented, but the acting physician felt that she had enough cognition to make a decision around whether to accept a treatment, which was surgery, versus doing nothing but keeping her comfortable. And in the end, I would have to agree that she did have that ability, but it took a lot of coaching from the family and from us to review the information for her to make that decision. So, I wish it were a little more black and white. Shemai says, I wish they had someone who put all of that together and gave us a whole picture. Absolutely. It's hard following through with each new hospital person. You're right. It is. And then if you're in the emergency department for a long time and the staff changes,
so we're getting a couple of observations here, Wendy, about POA versus representation agreement. And I don't know that they are the same thing. I think the representation agreement is more addressing the health care versus the POA, which is around more financial.
Yeah.
So this one question, my aunt had a rep agreement. They named a couple of individuals who declined to then act in their role. So then she, who's the POA, and along with another individual, could they then step in to help with this situation? That gets tricky.
Yeah, it does, because, again, there are some people who have POA, and depending on the health professional they talk to, that they're going to take that as that individual having the ability to make some healthcare decisions. And that, again, it's not, I think it comes down to education of those healthcare professionals as well. But in this case, it says here right now that she had a rep agreement, and now those individuals have declined to act in their role recently. So you're the POA for her along with another individual. I think you still can make decisions, and I think essentially what you could also, that's going to be a legal, to be honest, that's going to be a legal question. That's something that I would actually ask someone at NIDIS, for example. But my experience is that if someone who doesn't have a representation agreement, but they have a POA, I often still encourage that individual to use that to say, I am this person's power of attorney. And that, we're able to assist in ensuring that they're getting the proper care needed. So in terms of Shemai, the GER to the doctors who prefer to ask the person with dementia over the POA, I think my point there was that sometimes it still is the person who's directing their own care. It's still their decision at the end of the day, but sometimes the role of a family caregiver to really help support that individual making the decision or ensuring they understand the information is really clear. Now, obviously, if someone is really demented or has a moderate to severe dementia, then that's then where maybe family caregivers do make or will have a little more influence around decision making. And I think that comes back to as family caregivers, how do we best ensure that when the individual is in the emergency department or the hospital department, how do we end up advocating for them through the right channels? So I just wanted to clarify that piece.
And so your next question, Shemai, it kind of sounds a little bit like maybe he was refusing to be placed out of acute care, but he didn't really know how to look after himself. So that also, we're going to be coming to that about discharge and, how you might be able to be part of that process before it actually happens.
Okay. I know we're going to digress a little bit sometimes from these slides. Okay, so we've listed some of the potential acute care healthcare teams, and there's the triage nurse, there's the emergency physician, there's other emergency specialists, there's the nurse liaisons, there's the nurses who are typically in charge, or and then there's other, allied health professionals in terms of occupational and physiotherapists, and they all have a different, role to play. So usually, well, in the ED, it's a little bit different than when we get admitted to the hospital. So I'm just trying to understand. I'm just going to go to the next slide just because I want to make sure I'm giving the right information. Okay. Oh, okay. This one is a complete discharge. So your care recipient is discharged from the emergency department with a prescription and or instructions for care, or your care recipient is admitted into a hospital bed. Okay, so the first one, they've done all the tests. They've indicated that they don't need to be admitted to the hospital, and it's unlikely that you're going to get a prescription or instructions for care. You might want to ask for something. It likely won't just be given to you. If you're concerned about what to watch for, that's what I have found, is that if I've been in the emergency department with a client and we get discharged back, I'll just give you an example. I had a client who had a hematoma, and had a hematoma, so like a brain injury. She fell and she had bleeding on the brain. And so she was in the emergency for about 6 hours, and they did some tests, and they indicated that they felt over time, like over 2 weeks, that this swelling in her brain would just decrease, and that she would be fine, and that they were going to discharge us. That was it. And so I said to them, well, what happens if, what should I be looking for? How do we know? She lives alone in her home, and we have no one monitoring the situation. And so then, the physicians started throwing around a couple of things that we should be looking for, which we're writing down. So ultimately, it's unlikely you're actually going to get a prescription or a sheet of paper with instructions. It's going to be really important that you're going to want to ask. And it's also, so for example, just this exact piece is do you really understand what the diagnosis was for your care recipient? Do you know what they indicated has happened in plain English? And do you understand, what you need to look for in terms of signs and symptoms? And when would you return to the emergency department? When's, you want to make sure that all that information is going to get faxed through to the physician, family physician, and asking when the next, when you should be doing a follow-up with the family physician. Is there any changes in medications, and do you have those prescriptions to get filled? Are there going to be any, supplies or equipment that you're going to need? So there's different individuals that are going to give you that. So again, it depends on each hospital, but so for example, in our local hospital, when someone's discharged, they're discharged by the emergency department doctor. And at which point, it's possible that you're going to have a conversation with the nurse as well, but typically it's with that ED physician. And so that's where they're the best people to give that information. And so I know it's hard. I know it's really hard because we feel, we're really kind of pressed for time. But, most physicians do understand if you say, I'm the individual who's looking after this person, I'm really concerned about them, and I want to make sure that, I'm able to care for them properly. Then I think that's one way to approach it. But in that instance, at the discharge piece, unless there's someone who, unless you want to ask the emergency department physician, is there a nurse liaison that I can talk to with regards to discharge and this information? But typically it is the doctor that you're going to ask all those questions because they're the ones that are going to have the diagnosis, they're going to have the treatment, they're going to know if prescriptions have changed, they're going to recommend when you go see the doctor next. Things that nurses are going to help with or an occupational therapist, physiotherapist, are going to be more things like a referral into, let's say, home and community care, or a referral to get some specialized equipment, or a referral into a possible community organization. So I hope that helps. Oh, sorry, it's awkward with this phone up to my ear. Okay, here we go. So just as an aside, they don't make headsets anymore for these portable phones in 2017. Just that technology has changed.
The technology black hole.
Oh my gosh. So discharge into the community, those were kind of the steps. And then the other scenario was if the individual is admitted to hospital.
Yeah, Shemai is saying, sometimes the doctors are too busy and the nurses don't have all of the information. That's tough. I don't know,
I know, and I'm trying to understand, though, Shemai, if that is in the emergency department or in the hospital, because those are two different scenarios.
Right.
I think that's just an important piece, because I think we're going to get to this piece around the admission piece.
Okay, emergency department in busy lower mainland hospitals. Okay.
Right. Yeah, I mean, I understand that all hospitals are busy. I mean, Campbell River on a Saturday night is ridiculous. So is St. Paul's. But having said that, yeah, I know it's tough. I don't know what else to say, because having not been there in the situation, it's hard to, the bottom line is that we often feel very rushed, and we often feel that people do not have time, and the individuals who are providing care, to our loved ones are not giving us the time that we need as family members and as people, in hospital. So
just a question, Wendy. Like a lot of folks are saying, are agreeing that it's sometimes really hard to get any information. Is it typical practice for the ED to fax ED visit information to family physicians?
Oh, that's part of the discharge planning piece. So it is faxed through. So
in the worst case scenario, and this doesn't help when you're immediately going home with your care recipient and you still really have no idea what you need to be looking at, but the next, as soon as possible, making an appointment with your care recipient's GP, hopefully they have one, and making mention of the fact that they have been in ED and did you receive a fax, because that would contain some of the information, right?
Yeah, as much as possible. Yeah.
Yeah.
I mean, I think
it's not perfect, but
it's not perfect. But I guess the other question is typically the type of information. Like I'm thinking, we are admitted to the emergency room. And there's only kind of two paths. Well, there's three pathways. We die, which hopefully is not the case. And the second one, of course, is that we're discharged home after testing, which just isn't always. Sometimes we're kind of left with a lot of like, well, did we really find out anything? And then Janet, your whole piece about doing a quick follow-up with the physician as soon as possible. Sometimes that takes 2 weeks. Is helpful. And then if we're actually admitted into the hospital, then that's a whole other scenario. So. Is it possible to get someone, I think there's someone on the phone right now that I can hear them breathing.
Oh, yeah, just if everybody who's on the phone could just mute *6, please.
That'd be great. Thanks. Right. Okay. Yeah. No, I'm here. I was just
Okay.
reading through some of these questions here just to make sure that. Yeah, the ER, it is a very crazy place, and it's a long wait, and, you know, depending on the situation and who's there, yeah, it's not ideal. I think all of us know it's not ideal to be in the emergency.
But, you know, here's the other thing, too. So as a caregiver, if you've taken and you've gone with your care recipient to the emergency, you could make notes. And then, as we said, if you have to wait until you're discharged home and you're at the GP office, at least you've got some record of what happened in the ED from your perspective.
And what tests were done, and and if you didn't know the results of those tests. Oh, sorry, go ahead. Sorry, Janet.
Well, no, I'm just going to say, like, the focus would be on what actually happened for the care recipient in ED.
Mm-hmm. Yes, and so I think that you make a valid point because, you know, when you do eventually get to see that emergency doctor, it's really important to write down like what tests were administered. You may feel like you may not get the results, but it is the obligation. Like from what I understand, is that, you know, hospitals fax all those test results to your family physician. And so if you don't feel like you've gotten the information you've needed, then doing a follow-up with the family physician and reviewing those tests is one way to piece together the information. But as a family caregiver, absolutely, you want to write down notes from all those conversations that you've had with those individuals and finding out what tests were done. You may not, you want to ask what the results are, obviously, but if you don't get them or you're not sure what they're about, then doing follow-up with the physician is really important. So in terms of the admission think-through, we're talking back. The very first question is, do you understand why your care recipient is being admitted? One thing that is very helpful is that typically when someone is admitted, they are assigned a acting physician at the hospital. But it also depends because some physicians have hospital privileges and others don't. And so that's a really important thing to actually know about your family physician and about your local hospital is, does your family physician have privileges at the hospital? So as in, will they be part of all the round process? Or if they don't, then there's the physicians that work at the hospital who are assigned to patients. And they're the key individual, understanding why the care recipient was admitted. But what you might find, like in most cases, and I'm sure we're going to have some dialogue in this in the chat box, is that you meet with the physician, whether it's the hospital one or your family physician, and you have to retell your whole story about why the person was admitted. So do you know which professionals are part of your care recipient care teams, along with their names? Of course, that's going to change, in terms of the shifts of, say, nurses and OTs and PTs. But typically, it's more maybe the role that the person plays. So if, for example, typically each patient has a specific nurse, and then they might have an actual head nurse, and so the nurse is going to feed information into the medical, into the medical records, but you might ask the nurse clinician or the head nurse for a synopsis of the day, or how things have changed. One thing that we usually recommend is that you don't, you try not to visit around shift changes, because you want to catch a staff person after they've had a day with your care recipient, or it's going to be them for a couple of days, and you can have an established rapport. So those are some of the more questions I usually try and find out is, how long is that nurse? How long is their shift for this week? Like, how many days are they working? Are they working on the same in the same unit? Will they be assigned to the care recipient for X number of days? What are their shifts that they're working, so that I can have a dialogue with them around kind of the day-to-day, how things are going. And they'll also know what kind of tests were done, and then knowing which of the staff for me to connect with to find out, results around some of those tests, like whether it's a physical therapist or an occupational therapist. And one of the first things that you can ask is to find out when the medical rounds are and when the best time to connect with the physician is, and to ensure that you or someone is available to meet with that family physician around diagnostics, treatment, and potential decisions. So that's one. And that's not always easy because it's typically, early in the morning. But having said that, it really does depend, because having worked in the hospital with particular clients, I've gone at various times, and I've been able to, like, sometimes I've had to wait for an hour to talk to the family physician, but they have come. And if you're a long-distance caregiver, it's really important that, that one of the things you do is you call, and there would be no way that the family physician would be available, by phone likely at that minute, but to explain to the liaison nurse that you're a long-distance caregiver, you're concerned about your family member, and that you'd like to have the family doctor, or you'd like to have either the hospital physician who's treating your care recipient call you to discuss. And again, it might, you might not hear back for a long number of hours, and so you want to make sure you have a number that is on you, and that you're available, that you can make yourself available. Because when the call does come in, it's really important that you're able to pick up, and it's going to seem like your life is on hold, but that tends to be the situation. So hopefully those are...
Sharisha has an interesting question about do caregivers get an information for caregivers handout when they accompany someone who needs care, and Wendy's making the point that every hospital is a little bit different and situations are different. Yeah. What I can tell you is that there are lots of initiatives underway. This is recognized as an area that needs improvement across the health system. Mm-hmm. And so there are a lot of initiatives and projects underway to improve the experience for both patients and family caregivers when they go into acute care, either for admission or an ED visit. And I think those kinds of things are starting to happen, Sarisha. So it may not be happening in your local hospital, but I think we're starting to see some more spread of those kinds of initiatives. I don't know if that's any comfort, but you could also ask when you go to the when you're in the ED, who is the liaison nurse, or as Wendy pointed out, which GP has been assigned to my care recipient, or who's the charge nurse. Those kind of questions will help you navigate.
And I think what's really important, and that's also in hospital as well, not just necessarily. In the ER, that's important as well. But it's really important just to have a notebook and pen with you at all times, and to record all conversations, and to get people's names and roles so that you can refer back to those notes. Yeah, and it is an area that requires major care, and it really does depend on which hospital you're dealing with, and it's very different between rural and urban as well, and I think that's just really important to recognize as well. Okay. We've covered a little bit about this scenario. Your care recipient has been in hospital for more than one day. Who do you check with re-status? You can't be at the hospital all the time. Who is the best healthcare provider to check with? Is there a better time of day? Is it reasonable to ask for someone to call you? Yes. What happens when there's a staff rotation? Okay. So we've covered a little bit of that. I've written down some notes here, so just bear with me while I turn my head here. Okay. So, I mean, one of the things that is typically the, kind of the best people that we want to connect with regards to health status, general health status is, and progress. Typically that's going to be either the head nurse or the nurses. And I think depending on what someone's admitted for, we want to try and get information on their physical and their cognitive and their emotional well-being. And then one of the really important questions is to ask, if that's a change from previously, or if they're noticing some if things are irregular, or if they're concerned, what does that mean for the future, or have there been other tests ordered? So that's like the general functioning. From what from my experience, and if this is different for other individuals, please chime in. But typically, the physician or the family doctor, they're the ones that are doing diagnostic and treatment. So they're the ones that are actually diagnosing the situation, determining whether that person can be discharged or if they have to be placed for other services, whether it's complex care or if they have to go into rehabilitation. They might get all the information, but they're the ones that ultimately make that decision. It's also really good to find out from the nurses, especially if the person's been in the hospital for more than one day, because we know what happens to individuals unless we're mobile, regardless of our age. We really lose strength and energy and muscle mass. So that's especially true for frail elders. Really, really important to understand what they're being assisted with, like what they can and can't do, and if there's areas that we can assist with as family caregivers, and if there's things that we can help with, like mobility, ensuring that they're walking up and down the halls, or if they're actually able to go outside for a walk, depending on the weather. Those are some really good questions to ask in terms of their functional abilities. I'm just taking a look at my notes because I had a few here that I want to make sure that I didn't. The other thing that you can do is while the care recipient is in hospital, is make an appointment with the family doctor to discuss the prognosis, especially if they're in there for a week. And if you're not getting information from the hospital, then go to the family doctor. That's often an important piece to consider. There can be some complications with that if if the person you're caring for, the doctor may or may not release information, but it's always worth a try. Is where I come from. Hopefully you have that paperwork in place. So it says here you can't be at the hospital all the time. Of course, who is the best healthcare provider to check with? I think we've talked about that. Depending on what you need, it's going to be two different people. Is there a better time of day? Again, it depends on who you want to talk to. So I have found that first thing in the morning after medical rounds is really good for connecting with physicians. It's not great for nursing staff because they've either just started and they haven't had a chance to really work with the patient. Usually, it depends on tests and stuff like that, but usually tests and other assessments they try and get done, kind of mid-morning before lunch, sometimes right after lunch. But so typically I actually find the best time to go is a little later in the afternoon before a shift change. So if the shift change is, around 3, then trying to head in around 2, I have found has been helpful around like a general situation with nursing staff and trying to find the occupational therapist or physiotherapist. But with the GPs or the physicians, the hospital physicians, I find in the morning or later in the afternoon at times. Again, it is going to depend, and you can ask. You can ask when is the best time for me to, if I can't be here all day, what are the best times for me to be here to get information? It's very reasonable to ask someone to call you. whether or not they follow up is another question. I think it's how you present information. So if you're the primary caregiver and you're concerned about your aging parent or you're concerned about, your son, and you can ask that the physician call you for an update around, diagnostic and treatment. So what happens when there's a staff rotation? Typically it takes a little bit, depending on who's coming on to the rotation, and if they're new, then they're going to have to review all the notes. And sometimes if it is a new person, it can be quite helpful to ask them. If they've been in there for a week, let's say, or if they've been in there for a couple of days, you might want to say, do you have any questions about, especially if the person you're caring for isn't able to self-direct. It's certainly helpful to be there to answer any questions or provide some support. Typically the hospital staff are quite helpful or quite happy to have that information. Okay, so we've got 10 minutes here. Right, okay. So in terms of some more think-throughs here, I got a little ahead of myself, sorry. Does the care team understand care recipients' medical history and medication requirements? If they've been admitted and they've been there for a few days, hopefully that's been collected. Of course, when they're doing their initial, like sometimes what I find what happens is someone's admitted, and kind of within the first 24 to 48 hours, they're trying to figure out what's going on. And so that's where being available to the GP or the doctor on site, and especially them in terms of history, the medical history is really valuable, or previous admissions or previous situations. That's usually where, as family caregivers or family members, that we can provide really, really good information that can help support the proper diagnostic. So, for example, if the person's been admitted and they usually use a walker, it really depends. Sometimes it's just easier to use the hospital equipment, but if the person's really mobile and they want their own walker, then absolutely bring in their own walker. It's usually quite crowded in there, but that's, usually just finding a chair can be challenging. And sometimes there's, the more comforts, like having additional fleece blankets, bringing in toothpaste and toothbrushes and makeup and hairbrushes if they're going to be in there for a little while is often quite nice. Most people I have found, if they're in that kind of diagnostic and treatment, they're not feeling well, they're usually not really eager to get dressed unless they're going to be going out somewhere, unless they're trying to feel better. And you'll often find that, I have found anyway, that most people will just stay in a gown because they just don't have the energy, or they're having all these tests done. So typically, in terms of clothing, that might be a little bit closer to discharge that you might be. But having said that, some people like to have their, their own nightgown, or a robe is often quite nice to walk around in. So with regards to the discharge piece, typically that's a very good question, but that typically comes once they're once a diagnosis is done. And so once that arrives, then it's really important to be able to ask the questions around the discharge piece in terms of all the things that we've talked about from the ER piece, or the ED discharges, individuals' abilities, where they're at functioning-wise, where they're going to need assistance, what referrals have been made to community organizations, when do they need to have a follow-up with the physician, what further treatment is being done, has there been medication changes.
Yeah, and we cover that on the next slide.
Oh, here we go. Okay. So and it's kind of interesting on discharge too, because they'll often say, okay, we'll discharge at 10 o'clock, and you arrive at 10 o'clock, and everything's not quite done. But you can usually kind of help with that piece. But typically, okay, when you know the discharge is imminent, it's just really important to know what's going to be required in order for return to home. So if there's been any referrals put into Red Cross for equipment, if you need a specific supply, if the medication has been changed, usually that's part of it. You have to go to the drugstore and get that prescription renewed. Depends on what services are coming in to help. If there is any, has there been a referral that's made to home and community care or any other, community-based, will there be follow-up if they're concerned about future care? Usually it's up to the family or the care recipient to be making a follow-up to the doctor. If there's been a specialist, that's different. That referral's probably gone through, so you can kind of ask, when can I expect, to get a call with regards to the specialist. So those are some of the possible scenarios. And so if there has been a medication change, it can be helpful to have a review done to make sure that you understand the changes and why the changes were made. One thing I'll say with regards to home and community care, so if you're dealing with an aging parent, they've been hospitalized, and it's been determined that they would benefit from home and community care, what I have found is that if it's a bit of a push to get it done, then you want to make sure that you're home all day, because you don't want to miss those appointments to have services start as quickly as possible. And the point about, when they come to assess the needs, don't underestimate. Don't paint a picture that's better than what it is, because it's a lot easier to remove services than it is to have services put in. And it's also really good to understand what exactly is home and community care going to provide. Have them write it down in terms of number of visits, the length of those visits, what they're going to actually cover, so that you can fill in the gaps if you need to with either yourself or if you're going to look at other private care. And of course, just trying to make sure that all your care recipients' medical records are up to date.
Yeah,
right. And
Shemai
said,
agreeing. Yeah.
Yeah.
Don't let go of things too early.
Phew is right. It feels like a lot, but it is at least a bit better when you know what to expect. So if there's any other, kind of last questions, it looks like we've got a few minutes that we can answer. And I'm sorry, I just felt like it was one big verbal
but that's what
diarrhea.
It's like. I mean, we relived the visit. So what we're hoping is now you have some ideas for how to prepare, understand what might make a visit more productive, the different ways that you can interface with the different staff members to get results, and please either download the tools that you see at the bottom of your screen, or we will also have these tools posted with the recorded webinar in about a week. We put them up on our website. So, someone's asking about refusing to take my loved one home. So that becomes a placement decision, I think. And that's where your folks in acute care would be liaising with their folks in residential care to find the correct placement.
Gosh, they put me in a taxi.
Oh dear, yeah. Yeah, it can obviously create some very, very difficult situations for caregivers. And I think, Shemai, you were saying that there was a cognitive deficit in your case, so it makes it really, really tough. But to the best of your ability to try and advocate for your care recipient and for yourself as the caregiver. Yeah.
Yeah, I know. It's so hard. I'm sorry. I know that we have kind of some very specific examples, so it can be really hard to address everyone's specific needs. I guess the one thing that I can suggest is that being kind of really objective about what you're seeing and why, for example, you're not able to provide care is really important, and having some specific examples I think is helpful. If, for example, you just simply cannot take that person home, I think it's also important to know that, kind of understanding what then is going to happen if that's the case. I'm sorry. Oh, geez.
Yeah. Well, you know what? I think in that case you have to go back to the emergency.
Yeah.
I mean, and really, you're not left
the
with
social worker on board as well.
Yeah.
Yeah. I mean, having a social worker. I don't know all the scenarios. I'm sorry in terms of the details, but Yeah.
So I'm just
so
going to
sorry.
jump
That's
in here
challenging.
and make one last announcement. There's an opportunity to continue a chat on this topic. If everybody can just look at the slide that we have up on the screen, the Caregiver Network has created a tool called Huddle. And this allows all of us to sign on to an online chat. So, sorry, there's a spelling error here, but it's www.huddle.com. And if you go to that website, you will be able to join Huddle, and then you ask to join the Acute Care Huddle. And we have already started a bit of a chat going on in that Huddle. And so it's a way for all of you folks who are online and others to kind of share some of your common experiences and benefit from each other. So we invite you to continue this chat on acute care. And to end on a positive note, as I said before, there is lots of work happening across the country in terms of research and pilot projects, and some of that is posted on the Huddle around patient and family caregiver experience in acute care. And chats like this help others know what's important to caregivers, family caregivers. So please contribute. It would be great to have you continue to provide your thoughts. And I want to thank you very much. Thank you, Wendy, for a great job. And thank you all for joining us. You can.
Oh, it just says it's not live yet. Okay.
Okay. All right. Well,
we'll work on that one.
We'll look after that.
Okay.
All right. So thank you so much, everybody, for joining us. Bye for now.
Thank you. Bye-bye.